Maternity and Neonatal team. And welcome to our Summer Learning and Sharing webinar. The theme today is digital innovation. And as I'm sure you all know, this is one of the main topics in the 10-year delivery plan of the three major areas, analog to digital. And I have to admit myself, not an area I'm particularly au fait with. So I'm hoping to get some learning and sharing myself from our presenters today. Next slide, please. Little bit of housekeeping. Please mute your mic during the presentations. Raise your hand if you've got any questions to ask or to make a comment. And please feel free to put anything into the team chat as well, so we can ask questions in the question and answer sessions. And as you know, it's been recorded, so it'll be on our Futures webpage and on the network site. So to kick off today, to start with, we've got Laura Harmon, the new chair of the South East Maternity and Neonatal Digital Network, who's going to give us a brief overview of digital within the South East region. Over to you, Laura.
Thank you. Morning, everyone. So I'm Laura. I'm the digital midwife at Buckinghamshire Healthcare and also the new chair of the South East Maternity and Neonatal Digital Network. This group is also co-chaired by my colleague Roxy at Frimley Health, who is new into the role and is a great asset to the team as well. I'm delighted to have been requested to start off the agenda today, and it includes some fantastic topics, and I'm really looking forward to hearing from our speakers. The topics are highlighting how digital innovation can make such a difference to the care we provide. Digital is currently a huge topic for everybody, as we know, and it's only going to develop further. We currently have lots of trusts currently embarking on new procurements of electronic patient records in the South East, so that will only develop further over the next sort of year or two for a lot of our trusts. Across our networks, we've seen how digital tools are no longer just enhancements. They are enablers of safer, more equitable and more personalised care, whether it's through interoperable records, real-time data sharing or digital inclusion. Our Maternity and Neonatal Digital Network supports that digital work going on across the region, and we also act as a community which brings the digital midwifery, neonatal and obstetric colleagues together. We support each other through digital innovation, whether that's sharing ideas, escalating concerns, or just having a good chit chat sometimes, which is always really helpful as well. One thing that we've worked on recently is the Fixing the Digital Divide campaign, which has been a national drive, but we are really pushing in our region still, and that's to make sure that we are actively addressing digital exclusion and ensuring that nobody is left behind. The group is open for anybody with an interest in digital to join, and we hold bi-monthly meetings at the moment, and we also do have a future site. So if anybody is interested who is with us already, please do just reach out to me or Roxy, and we'd be more than happy to welcome you to the group. Thank you.
Thanks, Laura. So as you said, if anybody wants the address, let us know, and we can set email address, we can send it through to you if you're interested. And now for our first speaker of the day, it's Jo Page, who is an expert by lived experience, ORC, and we're very, very pleased to have her today to tell us about her experience, and it obviously set the scenes for talking about the new Wellbeing, Exercise and Pregnancy programme that's happening in Sussex. Thank you, Jo. Over to you.
Thank you. Before I start, thank you so much for listening and taking the time to listen to my story. So you're wondering why my birth story has any relevance to present day, but sadly I know firsthand from the work I do alongside OAC support groups that my story is all too relevant. What I'd like to get across is the long-term impact and the life that's lived when the mother leaves hospital after an obstetric injury. As busy professionals, these women will never come into your thoughts again, but after hearing my story, I hope you think of women like me, and that's how changes will happen. I had my very longed for baby and sustained a nasty tear. I felt I was very well prepared for the birth and therefore totally blindsided by what happened to me. The tear involved my back passage. I had never heard of this happening. I was not repaired in theatre or given antibiotics, again something I did not think of, and consequently ended up with E. coli, sepsis and the breakdown of my repair. I was shipped off to a side room where I stayed for days trying to cope with what had just happened and navigate my new normal. I was broken. My husband said that he watched the wife he brought into hospital disappear in front of his eyes, mentally and physically. He was taking home someone completely different. Life after that was very hard and consisted of looking after my wound and a new baby, laxatives, cleaning feces from my vagina and back passage, bowel leakage, pelvic pain, incontinence, sores and infections, self-loathing and self-harm with suicidal thoughts, hatred for my baby that had done this to me, even though that was far from the truth. I longed to take my baby to classes like other mums. I missed out on so much. Sadly, life was never to be the same again, all from having a baby. I had to eventually give up my job as I had little to no bowel control. I medicated to stop myself going to the toilet, but then the next day was spent trying to manually extract feces as I have no internal sphincter muscle control to push anything down. I would have to use irrigation and anal plugs, but they were uncomfortable and I was so ashamed. I would get in such a mess. Clearing up your own fecal matter from your shoes where you've trodden in it is so degrading. Family life was compromised. Leaving the house was a mission. My marriage was at an all-time low. Sex was non-existent due to soiling myself during or having to irrigate before. I lost my dignity and my self-worth. I longed to feel like a woman again. I tried so hard to get help over the years, but the hardest part of my story is that much later on, when I had tests at St Mark's Bowel Hospital, I found the extent of my injury. I learnt that things could have been very different. I had not had a proper repair for the injury, and the anal scans saw I had nearly 3/4 of my internal anal sphincter missing, and this had never been seen at the birth. My colorectal said that if the damage had even been found early postnatally, I still could have had a repair and my life would not have been as hard as it is now. But sadly, after time, it becomes irreparable, as mine is. A repair straight after birth can be successful if the right tear is diagnosed. I still have the same issues 29 years later and see various healthcare providers to keep me going and cope with life, but the shame of messing myself will never leave. Along with the intense pain, life is hard and will only get harder as I age. Stoma surgery is an option now, but that in itself does not come without issues and not something to be taken lightly. If you have Crohn's or colitis, you have a stoma to save your life. Having one for a childbirth injury is mind-blowing. I work alongside amazing support groups helping to raise awareness and helping new mums with an OAC injury navigate their new life. So this is where my story is sadly still happening, and there are new mums in the groups daily. Young women who sustained an injury and have since lost their jobs, got into financial difficulties, marriage breakups, mental breakdowns, and numerous surgeries that have failed and stomas fitted, all from normally misdiagnosed injuries. I've seen photos of friends' sphincter repair surgeries after the original tear was missed, and they are brutal. They have to endure numerous surgeries and hospital stays, as well as having to be a mum and a wife. Most of these women could have had successful repairs with simple changes. One woman asked for a rectal examination as it was her third baby, and she knew it didn't feel right to have such pain in that area, but was told it wasn't necessary. She's now having a stoma 7 years after 4 failed repairs. I needed to be repaired in theatre to see the extent of my damage. These are simple things. All of you are amazing professionals in the jobs you do, and many midwives I've spoken to about life with an OAC injury say that I am in their thoughts now when at work. And if my story can do one thing and promote change, then that makes me so happy, as I'm not ashamed to tell my story anymore. What would I like to see as an OAC mum? I think tears should be spoken about at antenatal appointments. Any other procedure, you are always made aware of what can go wrong, albeit rare, but not with giving birth. I really feel knowledge is power. The importance of understanding why maybe having certain checks and examinations postnatally or being referred to a pelvic physio should be explained to new mums. Both my injury and so many more I know would have benefited from these. I learnt so much about my injury from my pelvic physio. I think severe tears should be spoken about freely and not made to think they don't happen or are shameful, as I have heard midwives say that what happened to me doesn't happen now, and I for one know that that's not the case. My quality of life would have been so different if these things had happened for me. Also, the OAC package is amazing, especially with the aftercare help, as no one should have to try to navigate this injury alone while trying to look after a baby. The impact on the family is extreme. Myself and other mums had no idea where to turn to for help, and sitting in a bowel hospital having hideous tests after having a baby is so hard you wonder how on earth you got there. The gap I and so many fall between when trying to get help is where to send us. The divide between obstetric services and colorectal is massive for an OAC injury. I feel so hopeful that injured women will now have the care they deserve. Working as a service user alongside professionals like yourselves that actually want to make changes and prevent women living the life I have makes me both happy and truly honoured. Thank you for listening.
Thank you, Jo. That was absolutely amazing. I'm sure everybody has taken that message to heart, and hopefully the next presentation will show you how we're moving towards trying not to make that happen again. Thank you very much. And now we're going to move on to our next presentation. Hard one to follow, sorry ladies. And it's Isabella Dalmeida and Andrea Yeboah-Regis from Sussex, who are going to talk about wellbeing and exercise in pregnancy programme that they have developed online. Thank you.
Thank you, Sian. And yes, you're right, that certainly is a hard one to follow. And thank you so much, Jo, for sharing your story. Really appreciate it. So we are going to be talking today about the Wellbeing and Exercise in Pregnancy programme. Just to introduce ourselves first of all, so my name is Andrea and I'm a team lead for the Pelvic Health Service based at Worthing Hospital, and also the project lead for the Wellbeing and Exercise in Pregnancy programme.
And I'm Bella, and I am the professional lead for the Perinatal Pelvic Health Service for Sussex LMNS, and I'm also the service lead for the pelvic physio team across MSK Sussex Health. Next slide, please. So today we're going to talk to you about our free online Wellbeing and Exercise in Pregnancy programme, also known as WEP. We're going to talk about why we decided to create it, how we did it, the current content, what we found a bit tricky in the process, and some of the successes, and then what we plan to do next. So next slide, please. What we're going to do is just start with a short video. I hope. Thank you. So that was one of two videos that we've created that can be played in GP surgery waiting areas or antenatal clinic or in the physio area. And as it says, WEP is a free online programme for pregnancy and the postnatal period. All of our service users across Sussex are directed to the programme at booking. And it comprises of 4 main sections. So you've got your exercise video section, which is an extensive library of different exercise videos from Pilates to Zumba to gym ball, and we've got some HIIT sessions. It's worth noting that all of our instructors are specifically trained to work with obstetric patients. So we have midwives, we have maternity assistants and physiotherapists. The videos range from anywhere between 10 minutes and 40 minutes. I suppose the average is somewhere between 10 and 25 minutes. And then we also rate them in terms of difficulty. So we've said we can highlight the gentle exercise videos, the moderate ones, and then the more advanced ones. The next section is what we call our spotlight on. So these are bite-sized information videos. They range from between 1 and 3 minutes, I suppose. They cover lots and lots of different topics. So from pelvic health myth busters to pain control in pregnancy, barriers to exercise. We're developing new ones. Jo will be happy to hear about perineal massage and what to do after sustaining a tear. And then the other section we have is our rest and relaxation. So this is promoting the benefits of relaxation in pregnancy and the postnatal period. These are all audio, not videos, because that wouldn't be audio, but audio takes. And they range from grounding techniques with Annie to a sense of calm, finding a sense of calm with Kerry. And they're various different lengths. We also have a healthy living section. These are written resources on a range of topics to do with healthy weight and healthy food choices. They were all written by our specialist diabetes and maternal health dietitian. And we also do cover some specialist topics such as diabetes in pregnancy and pregnancy sickness. We then also link to relevant other videos that have been created around mental health and healthy weight. And then finally, we have a resource and FAQs section. So this was developed from questions that we get repeatedly from our service users. It's information and then links to further information, and it's a range of topics again, ranging from how often should I exercise? The one we hear very often, which is, will PGP go after I've had my baby? And then other stuff like when can I return to running? So that's your general overview. I'm going to pass on to Andy to talk about why we created the programme in the first place. Next slide, please.
So as Bella has spoken about, there were a lot of fundamental principles that we had when we created WEP. One of those was around the need for consistent and evidence-based information consolidated with our exercise videos, both within pregnancy and the postnatal period. So we wanted to make these videos and resources available across Sussex, and wanted to ensure that both our users and also our maternity professionals, healthcare professionals, had the same information available. So we could be confident that someone coming to our clinics had been given the same information by their midwife or by their consultant as we were given them. We were also wanting to promote both the physical and the mental benefits of exercise, because we know that those two are very much interlinked, and make sure that our users felt empowered that they were doing the best thing for both their pregnancy health, but also the health of their unborn baby by participating in exercise that was right for them and having the knowledge as well that could empower them. And we were very keen to work with specialist teams. One of the benefits in working in an acute setting and working within healthcare, so we wanted to make the most of the expertise, tap into the expertise, so that we could hopefully help as well to reduce the risk of maternal morbidities such as diabetes, and also pregnancy complications such as preeclampsia and stillbirth, with our emphasis on healthy living. And just to say as well that we are actually in an interim period at the moment. So we are talking about the resources that we have for our new website, which is going to be finalised in the next couple of weeks to a month. So some of the new resources are going to be specific on that new website. Next slide, please. Thank you. All of our funding to date has come from Sussex LM&S, and we just wanted to give a massive thank you to them, because they have been so supportive to us throughout and really supported the programme and our ethos. And we now have put forward 5 successful business cases, which have really helped us to be where we are now. We've also put the emphasis on collaborative working, so we have had service user input, we've had specific focus groups, a steering group, and then just general input from our maternity colleagues, from our public health colleagues, and we've tried to take everything into account to get us to where we are now. Definitely worth saying that we have used the same film crew and website design company throughout, and that has been great because it means that we're all now on the same page with respect to our goals and our philosophy and aims. So the programme is now in its second year, and worth saying as well that we did pilot it for 4 months just locally at Worthing and St Richards before we rolled out across Sussex, just in order to enable us to iron out any difficulties we may have encountered. And the same will apply now to our new website. We're planning a soft launch for a month, again, just to tease out any difficulties that we might have and have the chance to change them before we go fully live. Next slide, please. So just wanted to look at some survey results. So just showing that WEP is making a difference to our populations. So looking specifically at things that are really important to us, that's ability to be active and confidence to exercise. So we are finding that 68% found that they had a moderate to significant difference in their ability to be more active, and over 72% felt that WEP had enabled them to be much more confident to exercise. And you can see that that's in contrast with very low figures who felt that WEP had not made any difference to them. And it's worth mentioning in all this as well is that our website is fully inclusive, as we have translatable resources into over 100 languages, and that's a really big plus we find with our populations as well. Moving on with the survey results, so if we look at specific areas, so if we look at pregnancy-related aches and pains, so over 63%. Excuse the background noise.
Can you hear that background noise? Oh, good.
Brilliant. 63% found that WEP had made a significant difference to their ability to deal with aches and pains. And also very important to us, of course, as pelvic health physiotherapists, is pelvic floor exercise. And again, over 80% felt that they had enhanced knowledge about pelvic floor exercises and the ability to do those exercises correctly. Next slide, please. So moving on to talk a little bit about our challenges and wins. So we have acknowledged, we know it's difficult to get statistics, and that is one of the things that we have put in place for our new website, which will have an inbuilt user feedback survey, so that as people are using the programme, they hopefully will be more inclined to provide feedback. Marketing, we started off from a centralised position, and then we realised with the programme expanding that one person providing the marketing across numerous sites was not realistic. So we now have a system in place where we are going to have ambassadors based at each site and within specialist services, and they will be responsible for the marketing for their areas. And then online platform. So of course, we really feel that we've reaped the benefits of having an online platform. It is worth mentioning that through our focus groups and through our steering groups that we have thought about and spoken about perhaps having live WEP classes available online and or taking the WEP concept out into the community. And that's ideas that we have for the future. In terms of wins, overall, we've just had fantastic feedback about the programme. We really have felt that it has brought people together and improved communication within the MDT. I'm conscious that we're running out of time, so I am going to speed up a bit for Bella to just talk about social media. Yeah, and one other thing, massive win, sorry, which I should mention, is that we have sold to another trust, and that is very much something that we're hoping to do more of in the future, to be able to take any profit that we make to plough back into the programme to further enhance it. Next slide, please.
I think Andy was talking. Do you want to mention anything on that one?
Yeah, so the main thing that I was going to mention was about just raising awareness and working as an MDT. And I think Bella will just talk about the social media, which we're also using as a platform to promote WEP.
Next slide, please. Wow, that 14 minutes goes really quickly when you're presenting. I'm going to try and speed up now. So you know that we, in terms of promotion, we have midwife support, physio support, health visitor support, but we did want to extend the reach out. We know that everybody is on social media at the moment. So we have an Instagram and a Facebook account, and we use that platform to direct them back onto the website where they have all of the information. It's really different to what is housed on the website, obviously. We post twice a week. We set a monthly challenge. One of the posts is a monthly challenge, and that can be from the squat challenge to do your pelvic floor exercises 3 times a day, please challenge. And then we also have a did you know, and these are just little slides saying various topics. Did you know strength training is recommended twice a week during pregnancy? Did you know that 1 in 5 people suffer from pelvic girdle pain? We do have, and we're collating more little snippet videos from consultants and midwives and other MDT that just do a little 30-second, this is why we love WEP. And it just shows to service users that it is really backed but with an MDT approach, and that we're all singing from the same song sheet, if you like. Okay, I'm finished, Sian. Sorry, did I overrun?
Just for testimonials.
It's fine. It's really interesting.
We've just got
So
a few testimonials, but we won't. Yeah, just for you to see the positive feedback that we've had. So just talking about benefiting from safe and effective exercise videos, supportive resources, and helping to build user confidence.
Great.
So I'm happy to answer any questions. Thank you for listening.
Great. Yes, thank you very much. And indeed, it is the time for questions about both Dr. speakers today. And thank you to both of you very much. Any questions from the group? If you'd like to put your hands up or put it into chat, more than happy. Lauren.
Hi, first of all, I want to say, as a clinician using this platform in Sussex, I cannot say how useful it is enough to you. Honestly, it's so accessible. I use it a lot with women who have arrived as asylum seekers, because it was such an accessible resource to explain things. The visuals are brilliant. The videos are great for all sorts of service users. I cannot tell you how amazing it is. And we incorporated it in our antenatal classes as well. So from a clinician feedback perspective, which you didn't have as much of there, I just wanted to let you know how useful it is and how much easier it makes our job. And then from a sort of 10-year plan perspective, this is so much about prevention. So you're really like ahead of the game there. And there's a real research opportunity. And I wondered if you guys had considered that in your next step. Sorry, you whizzed past that slide, so you might have written it on there. Sorry.
Well, sorry, Lauren, you faded out a little bit there. Can you just repeat the last bit of the question?
Oh, sorry, I just said from a next steps perspective, I didn't quite see that slide, but I wondered if you considered the research opportunity in this, because it's so ahead of its time already, and like meeting the next steps, and I wondered if that was part of your plan.
Yeah, funny you should say that, because it is in an ideal world. So it'd be great to link up, actually, Lauren, and really happy that you found the resources helpful. And as I said, the new website, which is going to be out in the next month, I'll take your details and make sure that you're one of the first to see it. Hopefully we'll consolidate everything even more. So yeah, be good to chat. But yes, in terms of research, absolutely looking at accessibility, looking at equalities, looking at the translation resources. That's one of the areas that we've considered, absolutely.
And from a service point of view, looking at how it affects our figures of those actually accessing physiotherapy and other services, because the plan is to stop them getting through those doors in the first place. So if they've got all the information and advice before, then we have seen a decrease in our patients with pelvic girdle pain, because they're accessing the stuff first, so they're not getting to us. And then we have found that it's made an effect on our new patients to follow-up ratio, and that it's reduced it, because we see a patient, we can direct them to the resources. We know that if they want to, or they can come into one of our classes. So it's really helpful for trying to manage a really overrun service, which I'm sure
absolutely.
everyone understands.
Anecdotally, I can 100% support that. So for PGP in particular, and just those early signs, if you could give people that video resource, explain what it is, really good teaching as you do on your videos of how to do pelvic girdle exercises. And I found my referrals to interphysios went down. So that's what I was thinking from a research perspective. That's hitting all the aims and keeping it in the community and prevention work. It's brilliant. Well done.
And we're also using it, just following on from Joe's presentation, we're going to use it to educate service users on the Oasis Care bundle. So making sure that they're doing perineal massage from 34, 35 weeks, that they know to ask about manual perineal protection, that they know what we've got a section on active birth, so they know which positions are good. So hopefully that will help as well in those areas too.
Right, thank you everyone. I'm sorry, we've got such a packed agenda, so if there's any more questions, would you like to put them in the chat? And I'm sure our presenters will be more than happy to respond to them as well, if you're happy with that, ladies.
Yeah, absolutely. Great. Thank you.
Thank you very much, both lots of you. Thanks, Joe. Right, we're moving on to our next presentation, which is about digital solutions to emergency equipment checking. And this is coming from the University Hospital Southampton, where they have also been nominated for an HSJ award for this project. And it's James Keefe, Lucy Price and Charlie Wall. Over to you.
Good morning, everyone. Hope you're well, and thank you for taking time to hear about our digital checks. Yeah, that's fine. If you want to slide through to the second slide. And there we are, as Lucy is a midwifery matron. I'm the digital systems manager, and Charlie is performance data analyst at UHS. So if you go to the next slide, please. So where did this idea come from? So this is around the introduction to the equipment checks. So we really needed to look at this in three parts. So it was a time efficiency, real-time tracking, and improve accountability of the equipment checks, which were on paper. So what we wanted to do was look at the paper processes and then see how we could streamline them using digital tools. So we looked at Microsoft Forms, QR codes, and Power BI dashboards. So using these tools allowed us to reduce the administrative burdens and provide real-time insights through Power BI. So that would help support the staff and improve patient safety. And where we're talking about accountability, we created an efficient and more reliable system with paper. They can be put into folders and put on a shelf. With the digital systems, it allowed us to go back in and view the data, which you'll see on the slides coming, a little bit easier, and provide that data back to the relevant teams a lot quicker. So the next slide. So paper-based checks were why we started. Again, it was a low compliance, no real-time visibility. Audit trail wasn't there, and it was very, very manual in logging this information, and staff time was wasted. If somebody had done it in the morning, did the person in the evening know it had been done if the folder wasn't put back in the right place? So these were things we had to look at as a process overall. So you can move on to the next slide. So we looked at this through our strategic drivers, so our strengths, weaknesses, opportunities, and the threats for doing this. So the strengths, real-time compliance, significantly improving the patient safety. The digital tools allowed us to focus more on direct patient care for the midwives rather than going through and completing paper forms. The weaknesses that we saw across this were resistance from staff. It's going to that new digital platform. How do I use a QR code? Things like that. What's a Microsoft form? And again, dependence on technology. What issues could arise out of that? Opportunities here, opportunity to replicate this across all NHS sites that are using Microsoft Teams and Microsoft tools. And in the future, hopefully integration of more advanced technology so we can streamline this process. The major threats that can be there is cybersecurity, and budget constraints may impede that integration of further technology. The next slide, please. The implementation overall, we began at step 1 reviewing the existing process. We moved into developing the Microsoft Forms, Excel, which runs in the background of Microsoft Forms, and into Power BI. We set up multiple channels within Teams to host all of the Microsoft Forms, generated QR codes for each piece of equipment, and then out to a pilot. Only a few areas we touched on so we could figure out where we were working and where we were failing on there. And this is critical when you're introducing a change like this, is that you need to fail to be able to understand where you're going to push forward. So that allowed us to refine the system based on those observations that we noticed within the pilot, and then roll out of the full digital system, monitoring that with the performance of the BI dashboard. Next slide, please. This is a CBG machine. This is where what we were looking at previously. So you can see on the left-hand side the paper form. You can see the gaps that are there throughout the month. We're not achieving what we want to achieve with the paper form. So moving that over to the right-hand side, which is the initial screen of the Microsoft form. And on to the next slide, which I believe will be Lucy taking over.
Thanks, James. So yeah, as James has sort of spoken about, as at the time when this project launched, I was the matron for the birth environments, and so spending a lot of my time reviewing our sort of compliance and finding it really difficult. James walked in the office once and I was tearing my hair out with all these bits of paper. So in terms of what the clinical benefits and from my perspective as a clinician and the midwives working and our support workers, is that we've got such a better sort of handle on our safety checks, equipment checks in really critical environments of our hospital. We've got better assurance as a leadership team. We have better oversight. We can access the digital dashboard that we'll show you shortly from anywhere, which is amazing, really helpful for us. It's helped to improve our patient safety and compliance. It's saving clinician time, and it's, you know, at the end of the day also a cost saving. And in terms of what James has said around some of the initial barriers that we had, the staff are now in a place that they absolutely love it and are asking us, you know, talking about paper, why can't this be a QR code? So we really have got a QR code for everything now, and we're starting to roll it out with our cleaning checks too, which is great. Next slide, please. Is this Charlie now?
No, back one more slide. There was one more slide there for you, Lucy. That one.
Yeah, so here's some pictures of our midwives just doing some checks of our daily checks of resuscitators, drugs, grab boxes for emergencies. In terms of the wider impact across the hospital, so we at UHS are sort of a split site, so women and birthing people and sort of breast services, neonates, we're all on a separate site to the main hospital, which has its challenges. But one thing that we've been able to achieve using this project is that our resuscitation services can see our compliance with our resuscitation equipment from the main hospital. So it's also saving them time that they would used to have to come over and check all of our crash trolleys. So it's being rolled out into the wider service, which is really good to see that we're helping other people save time too. Thank you. Next slide.
So on here you can see us kind of clicking through the dashboard in action. So overall there were 72 different forms that used to be filled out, and they were moved onto the Microsoft Forms with QR codes. So for example, there's a check for cannulation that needs to be done, and all of those forms feed through into this one dashboard, which is shown on the wards, where midwives can see day to day which checks are needed left to do. So you can see that if there's still a check that needs, it goes red, and once they're all done, it will go green. And some you need to have, say, 7 or 8 different checks per form, and then when you hover over, which you'll see it loop back to in a minute, it will tell you exactly which equipment needs to be checked. And then on the compliance pages, it summarizes all of this up into percentage compliance by day and by month. And this is really what saved Lucy so much time, because she was previously having to go through manually through all of the different paper forms and add it up herself. And now this is all pulled through automatically straight onto the wards. Next slide, please. Yep, so this is kind of the technical process behind it. So there's a few different of the Microsoft tools that we use to build this. So from 72 forms, we use Power Automate, and it kind of generates one big data set that we can create the dashboard from. And then that's how they all get joined together. Next slide, please. I think this shows the impact in particular from introducing the dashboard. So you can see that the compliance for the few months before was holding quite steady at around 40%. And then from the introduction of the dashboard and then it getting used more and more on the wards, we can see that we're now hitting over 90%. Next slide, please. And then you can see here that in more recent months, that across the board compliance has been really high, and this is a significant improvement from what we were seeing with the paper checks before. So really goes to show how much of an impact this has had. Next slide, please. I think this is back to James.
Yeah, thank you, Charlie. So we wanted this to have a high impact, enhance the safety, improve operational efficiency, give staff empowerment. This was really critical here. So we had the staff, the people on the shop floor, telling us what would help make this easier for them. Because as soon as you say digital and change, a lot of the wall comes up, and people start to back off. So we had to make this as easy as possible. So right at the beginning, it was like, how do we do this? QR codes, as Lucy said, I think I create a QR code for everything. Probably will get one put on the back of my head so people can request a QR code from there. But it really does smooth things so much for the staff and the teams, and for ourselves in the background. That information pulls through to an Excel spreadsheet, which Charlie has been able to do her bit as well. And getting this done has been a real good piece of teamwork at UHS, because Charlie doesn't work within maternity, Lucy and I do. And we've had to reach out to the BI team, which is, is Charlie, and say, we've got this idea, how can we do this? So it's really showing that the collaboration that we've been able to achieve at UHS by saying, we've got this idea, Charlie being available to do all of this for us in terms of the BI. I've been doing the QR codes and the forms, and Lucy's been providing that clinical insight. Is the form doing what we want it to do? And is that information pulling through? So Alison, who's our digital midwife at UHS, provided insight on what she would want to see as a labour ward coordinator. So that staff empowerment from different areas within the trust has been really, really important. From Alex, our cleaner, who was our unwitting pilot, so all the way to Charlie, Power BI dashboards, and our chief nursing informatics officer wanting to roll this out. So it really has gone from, all ranges of roles within UHS. And we can scale it. As I've said before, if you have Microsoft products at your trust, this can be implemented. So we're looking at the SHIP, which is Southampton, Hampshire, Isle of Wight, and Portsmouth. So the other 3 trusts within that are looking at taking this on. Dorset are currently looking at doing this themselves, and we're providing information and support to them to do so. And that is everything. So I think the next slide is questions, if there are any. And thank you for your time.
Thank you, James. Thank you, all of you, for that great presentation. And to me, it looks very user-friendly, which is really important from my point of view. If you don't understand what's going on in the background, it's great to know you just have to push the buttons and scan things. It sounds great. Any questions? Liza?
This might be a really random question, but I'm a little bit neurodiverse, so technology is something that I take a bit of time to adjust to, even though I run a company that deals with social media, so that's very counterproductive for my brain. However, on a daily, when I'm the midwife working on a shop floor, how do I know that equipment's been checked? Does it still get signed off on a piece of paper so the staff who need to come and check it, or is it all on this digital pad, and you need the digital pad to be able to know if it's been checked or not?
Okay, if you could scroll back through the slides to the dashboard screen, if possible. 1, 2, keep going. Yeah, there. So that is on the dashboard. It will be on a screen on Labour Ward, on our Broadlands, which is our maternity unit as well. So this will show you that the check has been done. So anything in green has been done, and it's got the number in there as well. So what you'll see when it cycles back through is that the number of resuscitation trolleys is 8. So that will show as 8, and then it will drop all the way down to 1, and then that will go green. So it will tell you also there's tooltips, which is when you hover over the particular box, it'll tell you which resuscitator is left to be checked. So this screen here is what you'll see on a computer screen in that ward area.
Okay, that makes sense. And then say I happen to be a midwife on delivery suite and somebody's walked in, they're having their second baby and they're pushing at that point of time, and I'm in the room with the mum, I'm about to support her have a baby. How would I know that that resuscitator has been checked without going out and looking at the screen?
That would, I would assume, Lucy can correct me if I'm wrong, but the Labour Ward coordinator should be able to make you aware of that, because they're the ones running the floor.
Okay, that's great. Thank you so much.
That's okay.
It sounds like a really good idea, to be honest, but thank you for explaining that part to me.
No, that's no problem.
Trude.
Yeah, I'm just thinking in response to the last question, could you not have another QR code that takes you to that dashboard? That will enable the user to go directly.
It's literally in our midwife offices on every ward. We've got the screen up all the time, and it's on a huge screen, so you can see exactly which room, which resuscitator, what's left to be checked. Does that make sense? And the Labour coordinators.
Yeah, sorry. Go
on. Yeah, as James says, the coordinators are aware of what equipment has not been checked. Does that make sense? And wouldn't be ready?
I think for me as a midwife, that I would probably just check it again, which is obviously counterproductive for what you're trying to do. So if you were able to provide something that was instant, intuitive for the user at the time, then you would avoid that. That's just food for thought. That's kind of what the next step I would have taken that to, rather than having to try and find someone, particularly if you've got someone who is, you're dealing with them at the time, and then it's a necessary step out of the room. Anyway, get that in my soapbox. Thank you. That was really, really interesting. We have something similar in place at Medway, but we have an interface that does basically this. Out of interest, your Power Automate, who did that? Is that did you have departmental support for that kind of thing?
That was done between Charlie and myself.
Okay, cool. Yeah.
Hi.
Thank you.
Hi, it's Ali from Sash. Maybe a bit of a strange question, but from concept to implementation, how long did it take?
Probably about 8 months. So I was accosted in a corridor round about Christmas and said that this needs to be done. How quickly can we do it? So yeah, I then went away and looked at multiple different Microsoft tools that we could use, and came back with this probably within about 4 weeks of scoping out what would be the most efficient way to do it. And then it was a search for willing victims or unwilling victims. As Alex the cleaner, I handed him an iPad and went, go break it. And then we evolved from there on in, and Charlie became involved.
Time for one more question, Sian.
It's probably for the clinicians rather than James. So we have a very, very similar platform at Ashford St Peters, but one of the challenges that we have is if the equipment is missing or not working, you essentially can't complete your check without getting to the end of the form, so you can't move on to the next part. So if there is equipment missing or broken or out of date, how do you, because in a real-time situation you can't necessarily go and replace your laryngoscope on your neonatal resuscitator. Actually, you need to go out of the room, you need to go and find one. How do you do that in real time and still complete that check and actually know that the check has been done and everything, actually like that quality assurance of you've done the check, but is that check of a good quality and is the stuff in there actually the right stuff? Does that make sense?
Yeah, so on our the first question on our most of the checks, Charlie, I think, isn't it, is it available and is it working? And if it's not, what's the user done about that? Does that make sense?
So at the beginning of the check, but as in if you get halfway through your check and actually you realise you're missing some equipment or it's out of date. Oh, can you hear me? Yeah. How do you then manage that? Because you presumably have to sign that form off still to say you've done your check.
Can you give me like a specific example? So
yeah, so for example,
if we say a PPH trolley and we found some out of date drugs on it, we would replace them and fit
at the time. So if you're halfway through a check, you leave your check, you go and find your new adrenaline or whatever you're going to get and come back and then finish your check. Is that how it would work?
Yeah, I guess. Yeah.
Okay, fine, that's cool.
Yeah,
if you've
we
got
do
more
have
questions,
a comment section as well. It'd be good to go back and look at some of the forms to see. Yeah.
And so with the resuscitator is broken, they will choose that right at the beginning to say that it's broken, so it will be out of order. And the process outside of this will be for that piece of equipment to go back for repair, and it won't appear on the checks again until it's put back into service.
I'm more thinking about a piece of equipment that has, like your PPH trolley is a perfect example, has multiple things that you need in there, but actually you can be missing one piece out of your 100 and therefore your check still can't be complete and turn it green because you've got something that's not.
So you would go and get it, and then
would be to go and get that piece of equipment and put that back in there and then sign
Have you done anything looking at the quality assurance of actually what's in the trolleys and whether those checks are correct?
Yeah, they're regularly reviewed.
Cool. Perfect. Thank you.
Thanks, everybody. Sorry, we're pack agenda, so I'm afraid we're going to have to move on. But if anybody wants to talk to anybody else, I can put you in touch. No problems. Okay, our next presentation is the Village Voices podcast, Demystifying Modern Maternity Care. A quick introduction from Zishan Midasa from the Bob LMNS, and then we've got Pfizer with our presentation. Over to you both.
Thank you, Sian. So I'll do a very quick introduction. So as part of our equity and equality plan, we wanted to work with the Global Ethnic Majority or projects within that. And a big part of this was also the MNVP's work. So we did organize a collaboration between Bucks Maternity Neonatal Voices Partnership and the Rahan Project. And for those who are not familiar with the Rahan Project, they are a service user organization based in Cambridgeshire and Peterborough, working with Black and Asian communities, the South Asian communities. So they've done some really good work. I don't want to go into it in too much detail. I think Faiza will do that job much better than me. So I'm going to bring it over to Faiza. So Faiza, are you on?
Zishan, thank you so much.
Just a quick introduction to everybody. Thank you so much for having me. And it's really interesting actually hearing all of the innovative things you're all trying to do, because the midwife in me keeps thinking, oh my God, I need to go talk to my trust about some of these things as well. So my name's Faiza Rahman. I am a mother first and foremost. I am a midwife. I've been practicing for 17 years, and I started my community interest company called Raham Project 5 years ago. And it was started off the back of seeing firsthand, working clinically, that women from diverse ethnic communities were often being treated differently compared to Caucasian women within maternity services. And it wasn't just in one area, because I've worked in lots of different hospitals. There seemed to be a bit of a pattern in how they felt that they were being treated. Now, around the time that I started Raham Project, I began my own journey as a mother, and I started to really question what's happening to me as a mother or other mothers like me, and what I was seeing as a midwife. And I put two and two together and recognized there's one coin and there's two faces to this coin. And often what tends to happen to Black, brown, mixed ethnicity women who are service users tends to be happening to the staff. So for context, my personal journey, it has taken me 17 years to get into senior management as a brown midwife. I am absolutely that statistic in the res data that suggests that once you hit over the age of 30, you're a woman of color, that you are extremely unlikely to be represented in those kind of higher level forums, which is really important that we have those spaces, because we can talk about nuances that our communities experience that maybe not everybody else can. And saying that, we also recognise that the data is showing that they are having poorer healthcare outcomes and experiences. So this Village Voices Demystifying Modern Maternity Care was essentially a collaboration between Raham Project, and it was actually Shamila, who is the Bucks MVP co-chair at the time, who reached out saying, Faiza, there's something, you know, about your work that you're doing that I feel would really benefit people within our area. And we started having conversations around, you know, we need to start doing things differently. I always talk about the NHS, and I really admire it for everything that it does. But I often think in my head that it feels sometimes like people want to lose weight, but they keep eating lots of chocolate cake. We need to look at doing things differently if you want a different outcome. So this podcast was essentially that. We're going to stop eating some chocolate cake and really talk about what those, you know, nuances and those problems are that people from our diverse communities are experiencing. So this was our concept. This was really what we wanted to do. So if we go on to the next slide, I'll talk a little bit about the concept of the project. So the goal really was for us to engage diverse communities during the perinatal period. We wanted to use social media. So Raham Project is really hands-on with using social media. When COVID started and we started the organisation, social media was very much the way that we reached out to communities. And the key really was on focusing on service users' voices, but listening to where they feel the problems are, and then actually talking about those problems and helping them figure out, you know, where can they go for support? What can that look like? The aim really of the podcast was to help educate, connect, and share maternity care experiences, not just with families, but also providers. And I think this is really important. We need to recognise how connected intrinsically service user experiences and staff experiences are. So we need to really look at a much more kind of deeper level of adapting the way that we care and support people from those demographics, not just as service users, but also as staff members as well. So if we go on to the next slide. So we came up with this concept of we're going to create 12 podcasts, and we're going to cover various topics. And the topics were essentially decided based on what families were talking to us about. So some of the topics that we covered were breastfeeding, home birth. With baby loss, we worked with a lady called Arcia, who runs the Miscarriage Association. So we reached out, we collaborated with other groups as well and involved those service user voices. But essentially we covered 12 various topics, which are shown in this slide. I'm happy to talk a little bit more about these as we move forward, but we'll move on to the next slide, please. And this is really what our impact was. So we used social media quite vigorously over the last year. So the reach of all of the promotion of the work, we reached about 19,000 people through our social media channels. We got about close to 400 likes and reactions, which is really important because that means people are actually engaging with what we're sharing. And then Spotify is the mode that we decided to operate the podcast from. So it's up there, it's live, it's going to stay there forever until we decide to take it down. So I'm pretty certain these numbers will only keep increasing as we lead it out there in the social media realm. But we've had 513 plays and we've gained 50 followers. So I can see momentum is building. Just for background information, the vast majority of our listeners happen to be female. Over 50% of them happen to be between the age of 23 and 34. Now, the vast majority of our listeners are UK based, about 97%, I believe, or 96%. But then our next two countries that we're getting people to listen from are the US and Australia. And then the top two episodes that we posted were episode exploring the realities of women from diverse backgrounds. That was one of our top one. And the second one was breastfeeding. Can we move on to the next slide, please? Now, every episode that we did put out, we wanted to engage with service users to make sure that things are resonating with them, or is there anything else that they want us to be talking about. And this was some of the feedback that we got that I thought it would be really worth sharing with us all, just to understand exactly, how it translated to people who are listening. So one mum said the breastfeeding and home birth episode in particular resonated with me as it offered a perspective that I had been searching, having recently had a baby myself. A really important podcast covering topics with cultural nuance and taking into account the different experiences of women of colour. Faiz and Shumaila offer a lovely mix of lived experience, reflections, and real-time research and knowledge from their professional backgrounds. I have recommended the podcast to expecting friends. Now, that last line about recommending the podcast, word of mouth is super powerful within diverse communities. It's not always what you know, it's who you know and who's going to talk to who. And that is really important. If you want to build momentum and spread information, you want to tap into a few people within the community, and that's how the kind of snowball happens. Another mother said, just wanted to let you know that these podcasts are brilliant. I have listened to a few of them and really wish that I had known about all of this before having the first baby. It would have saved all the unnecessary trauma. And this is something that comes up quite significantly when we have spoken to people over the last 5 years. And I think it's really pertinent to note that when you speak to people from ethnically diverse backgrounds, if English doesn't happen to be their first language and they speak another language, words like trauma don't necessarily even exist in the vocabulary. So, for example, within the South Asian community, perinatal mental health isn't even a word within our vocabulary. So when I work with service users as a mother, but also, as a midwife, also as the lead of Raham Project, what I've learned is our communities describe symptoms. Women will talk about their symptoms. They won't call it mental health, but they'll say, oh, I've been getting really bad stomach cramps, or my heart feels like it's really fluttering, or I'm not sleeping very well. So they'll describe symptoms. So you've got to get a bit savvy when you work with particular communities. So it's really, I think, pertinent that this mother actually called it trauma, which is not often what we will identify it as. And then one last one, just on the bottom right-hand side, our mother said that this is brilliant, particularly because it's representing South Asian women. In my husband's culture, it is pretty rare women choose home births. We didn't tell his mum we were planning a home birth, and only when she visited once the baby was born, she found out, and she still thought I was bonkers. Now I can give this as an example for families to listen to. So that's some of the feedback that we've had, which has been really great to hear, because it shows that this podcast is making an impact on those women who are listening to it. And if we just move on to the next slide, we didn't just take on the project and think we're going to keep it to ourselves and not network. Part of working in the charity sector means we have to network vigorously to be able to get information out there. So we did work quite closely, and we had a couple of people who really helped promote it for us. So Better Birth is a well-known organisation that supports with policy change in the government. So Nikki supported us to get people to engage with the podcast. Ilya Morrison, she's quite a well-known midwife that supports mothers through birth trauma. And if you did watch Great British Bake Off, she happened to have been one of the contestants recently, which is where some people might recognize her from, but she also helped us endorse it. Sandra Igwe is the founder and CEO of the Motherhood Group, and she's done a lot of service user group works, research, support, and her organisation is mainly about supporting Black-led voices, which we recognise that women from Black communities happen to have the worst outcomes if we were to really look at the data. And then Binish Nazmin, she's the co-founder of Association of South Asian Midwives. and she's got quite a few links into our midwifery workforce. And like I said, we wanted to kind of target service users, which Raham Project and Bucks was great at doing, but I also wanted it to go deeper than that, and we start reaching the staff as well. And then lastly, I just wanted to thanks Bucks for actually, or Bob LMNS for supporting and actually looking at trying to tackle the inequalities in a different way, because I'm going to say quite comfortably, after working with quite a lot of ICSs, not everybody has the courage to actually try to do stuff about it. We can keep talking about the fact that Black women are dying more, brown women are dying more, but we need to actually be active, because this has been happening since, say, my mum and my grandma were having their children. And really, by now, I think in the West, we should have been able to start looking at some real tangible solutions. And I think information and awareness and education is rising, and that's probably where we sit right now from my organisation's point of view. But I think it's really innovative of Bucks and Bob LMS for wanting to support. So thank you so much, and I'm happy to take any questions.
Thanks so much, Liza. And questions? Any questions? It's a great approach, an innovative approach to communities that need that extra support, and that I think we personally find difficult to link into and give the right messages. Any more questions from anybody?
I hear you, Sean, and I appreciate that. And I think part of the fear comes from you know, working within the West, when we have people who happen to be mainly Caucasian in these higher up positions, there might be this fear of, we don't want to get it wrong. And I hear this so often when I speak to people, my colleagues, my friends, anyone within the EDI world, that if I happen to be a white person, who am I to really push these things? But actually, what we need to do is we need to collaborate, and we need to pick up where our allies are, because that's how you raise, you know, the platform to these sorts of things. And regarding like equity and EDI and supporting diverse voices, that should be a thread right from, you know, the start of anything we do to the end. It should just be a baseline foundation. And like I said, some areas are quite keen to start new things and try and have a go, because the intention is what really counts with our communities. And even if we don't speak English as a first language, we are watching people's body language. We are seeing what their actions are saying more than what's coming out of their mouths. And I think this is a really important thing for people to recognize. Try, and it's okay if you get it wrong. Nobody's gonna, you know, kill you for having a go. But doing nothing, the silence feels much harder to sometimes bear, I would say.
Great, thank you. Bella?
Yeah, I think just wanted to say well done for getting
Yeah.
out there and doing it. I've already followed you on Spotify, so
Me too. You've got 52 now.
and yeah, just to say, we'd love to be in contact and collaborate potentially. And I think it's just so powerful what you're saying about getting out there and doing something rather than talking about it. One of the things that I'm working on, a bit of a long-term mission, is the decreased BMI thresholds for Asian women, especially with respect to gestational diabetes. And so we've had to sort of really work to get that in the trust guidelines, to highlight the fact to maternity staff that they need to be giving these women the opportunities to access classes at a lower BMI. You know, just a small example of one of the many things that we can incorporate into maternity care, which can potentially make a difference. So yeah, love to have a proper chat.
Thank you so much. Just reach out directly. And actually, whilst I was listening to you and the lovely lady that was talking about pelvic health, my brain was just thinking, I recognize that within, say, the South Asian community, you're more likely to end up having an extensive OAC, like an OAC. And I think there is something about prevention, which I know the Department of Health is going to really probably want to encourage. The 10-year plan is going to be looking at that, bringing it all back into the community, and looking at prevention really is what we need. Thank you.
Yeah.
Brilliant. Thanks again very much. And I'm afraid we have to move on with our agenda, running a bit behind time. So our next presentation is from Sian MacDonald from Ashford St Peters, which is consultant obstetrician, talking about Tommy's app. Thanks, Sian.
Perfect. Thank you. So I think I've got control. If I'm moving. it moving? Oh, here we go. I think it might be a bit tardy, to be honest. So yeah, I am Charlotte Online, one of the obstetric consultants at Ashford and St Peters. I'm feeling a bit sad that I don't have a team with us, because this is absolutely, it's not really my project actually. It's a project which is held by the Tommy's National Centre for Maternity Improvement. And we were one of four early adopter sites. Lewisham and Greenwich count as 2 separate sites. There is us and there is Jessop's, but essentially we were the early adopter sites for this big national improvement programme, which was supported by both the Royal College of Obstetricians, the Royal College of Midwives, and all of the data was initially held by NHS Digital. So this tells you actually this is not something that we have done locally, but our job was about that local implementation and on the shop floor. Some of you will have heard about Tommy's already. Baski is the Tommy's National Centre for Maternity Improvement clinical lead, and he's been doing loads of stuff to make it much more aware. But essentially the premise of it is about reducing stillbirths and babies who are born preterm. So around 2,900 babies are stillborn and 60,000 preterm births every year in the UK, but there is still huge variation across the country, and fundamentally that is the premise of the Tommy's app, is to try and reduce that variation, that you should be able to deliver your baby in separate units, but actually those risks are recognised and you're dealt with the same way. And those key factors in improving their care are about predicting the right women who are at risks, not using traditional checklists, but also using decision to support tools to try and reduce that variation in practice. Like fundamentally our antenatal care is all about reducing and managing those risks, trying to detect those risks both as an individual and the system, preparing parents for what might happen to them, enabling and supporting them to make choices and to sort of shape the course of their pregnancy. But on a bigger system, it's all about understanding your local population, making sure that your services support that local population. But the NHS, we all know, has limited resources, and for me as a fetal medicine consultant, our obstetric resource from scanning is absolutely key in part of this, and that's where we've seen lots of benefit for Tommy's. So if we think about traditionally how we would have risk assessed, and this still goes on in lots of units across the country, all of your pregnancy risks essentially account for the same. So you might have had a previous stillbirth, or you might have chronic hypertension, but you also might be over the age of 40, and actually your risk is completely different, but you are managed the same. So it's about saying that you also might have protective risk factors that can reduce your risk of having an adverse outcome. So yes, you might be a 40-year-old woman, but actually you might have had 3 pregnancies in the last 6 years, which have all had normally grown babies at term without any other complications. And actually all your checklist can do is recognise that you are a 40-year-old woman. What it can't recognise is that you have lots of other protective factors. That means that actually for you as an individual woman, you are probably low risk of developing significant pregnancy complications. But it also doesn't, our tick list, look at each individual risk factor as a separate thing rather than those additive risks or complications. And that is where Tommy's comes in, is about you want to be able to individualize that care. One of the other roles of Tommy's is about a decision support tool. We all know when it gets to 3 o'clock in the morning, you have a woman who's in triage presenting with reduced fetal movements, and you probably sometimes deal with that woman and care for her and provide her a different pathway of care compared to when it's 3 o'clock in the afternoon. Because we are human, actually, I can't keep my 93 NICE guidelines off the top of my head. And that is what is really, really hard as clinicians there on the shop floor. So what we need is digital tools to help us, to support us in making the right decision at the right time for that woman as an individual, understanding all of her risks and making sure that she receives the right care. So Tommy's is essentially an app, which is an app but not an app. It's a web-based tool. We did feedback. The app wasn't a good way to be able to describe it, because especially at the start of our rollout, women were really confused that we had an app, but they couldn't find it on the App Store when they were on their phone. So what it does is accurately assess a woman's risk of both preterm birth and placental dysfunction, provides her a personalised pathway for each woman. It's more sensitive. So women who, the aim of it is to make sure that fewer women who are high risk are actually monitored on a low risk pathway, but also really specific. So there are fewer low risk women that are labelled as high risk. Okay, so you are essentially detecting your women and their risks more accurately. Enables continuity of care for information about the pregnancy. So we have a healthcare provider app, but also the woman has an app that is on her phone that she can look at, that she accesses to her care, so that when it's 3 o'clock in the morning and actually whatever clinician sees her hasn't recognised that it's her second presentation of reduced fetal movements, she can say, yes, but my app tells me that I should be accessing a scan because it's now my second time of reduced movements, or actually I'm high risk of placental dysfunction and therefore my first presentation of reduced movements I should be having a scan. And that's really hard to be able to do in a busy triage setting. So that the app that's not an app has different settings. So all women have a preterm birth assessment, and apart from a very small sector of women, they will all have a placental function run. Essentially, the women who are excluded are those with chronic hypertension and those with multiple pregnancies. But most of them all have a placental function run. And then the app is used for at different touch points. So if you present with preterm labour, clearly fibronectin isn't now around, so we are trying to use more cervical length to be able to individualise that care. If someone, as I've already mentioned, presents with reduced fetal movements, they will have their app run to support what care they should receive. But also all women who have a scan who are placed on either a moderate or a high chance of placental dysfunction pathway will have a timing of birth run. So you essentially put in their estimated weight, their Dopplers. The app already knows that woman's risks and will be able to individualise and support the conversations around timing of birth. Tommy's is the lowest level of care that a woman can receive, so we can always upgrade it if we want. This is an example of what we see as healthcare clinicians. So we can see that woman's exact risk of placental dysfunction, and this is just showing you what the parameters put in. So it shows you her CRL, so essentially how many weeks she is, her booking blood pressure, the PAPE, and then the uterine artery. So it's looking at that woman's individual cardiovascular system to be able to look at that woman's risk rather than using our tick list. But also the woman has that view, and so it supports those really high quality conversations about why she is receiving the care that she is receiving. And this is just a little bit about our growth pathways over the last few years, because things have evolved massively. So I started at St Peter's in 2018, and just before I started, they had stopped Gap Grow, and their growth pathways were, to be honest, a little bit chaotic. It was all done on a sort of piece of paper. By that stage, we had already started to transition from paper notes onto Badgernet. So there was, again, that confusion. We didn't have those pieces of paper that we can just circle to say exactly what that woman's pathway were. I'd come from training lots of it at George's and at Kingston, both of whom were really progressive in the way that they were doing things. So very early after I started, we implemented second trimester uterine artery Dopplers and with training. And just before COVID, we had already moved to our sonographers risk assessing women at the time of their anomaly scan. So looking at that woman's individual risks using a checklist and doing her uterine arteries if indicated and putting her onto a scan and arranging those follow-ups pathways. But at that stage, all women who had a scan were seen by a doctor in day assessment or in an antenatal clinic, and we had women waiting for hours and hours. So as COVID started, we implemented a traffic light management scan, which I'll show you on the next page. But essentially, all of our scans are now green, amber, red, and it is very pathway driven. and hopefully minimises women waiting around unnecessarily to be told your scan's normal. And then we launched Tommy's in 2021 as a soft rollout. So obviously women were progressing down that pathway. And this summer there are the partner trial, which is the next phase of the Tommy's essentially trial. So they are recruiting, I think, another 32 units across the country to be part of Tommy's, looking at that wider implementation. And that's just our pathways. So for example, if you have a baby that is small, so a small tummy, or 3rd to the 10th EFW, it looks at that growth pathway. And it means that all of that is automated. The sonographers are absolutely amazing at flagging those women when they've got concerns. Just an example of why it's so helpful. So 34-year-old, para 3, all normally grown, normal BMI, stopped smoking in the first trimester. On Saving Baby's Life, she would have been low chance. She had a normal PAPA. She had a high chance EBT, but I had a low chance NIPT, so for Downs, Edwards and Patos. But on Tommy's, she was high chance. And you look at that and you think, how is this woman high chance? Because actually, she's got lots of predictive factors, but fundamentally in that pregnancy, not looking at her previous pregnancies, although they are important because they feed into the algorithm, that woman was high chance of placental dysfunction. And actually, she ended up having a very little baby in that pregnancy, so was induced at 37 weeks with a less than the first centile baby, but had the appropriate monitoring and actually had a good pregnancy outcome. The app also supports really high quality conversations. I'm just conscious of the time, but you can also see the clinical benefit. So we've had a reduction in the number of scans that we have been performing, but with improved detection rate of our small, less than the third centile babies, with no increase in poor outcomes. So absolutely, the app is enabling us to detect those women and identify the high risk women to make sure that they are on the correct pathway. And this is just some data from Tommy's. If you look at the total number of scans on a traditional Saving Babies Lives pathway compared to if we're using Tommy's, and absolutely we have noticed that reduction. It has not always been straightforward. We were imagining a nice straightforward uphill. The reality is that there have been lots of bumps in the road. COVID, loads of change. It was really challenging. Our sonographers, as you can see, had been asked to do lots of things and they were amazing at doing those things. But then we said, oh, that thing that we've just asked you to do, we now want you to do something completely different and to learn a new skill doing first trimester uterines. And so that was hard, but they absolutely embraced it. We've had lots of challenges engaging the team, and that is a continual thing because you will have both obstetric and midwifery staff that come from other units who are really used to scanning every woman who is age 41 and actually getting that message to our trainees that we are individualising care to make sure that everything is on the same hymn sheet, because absolutely what we don't want is women being told one thing in an antenatal clinic, they try and get their scan, and then and our sonographers and our admin staff within ultrasound are amazing gatekeepers, and they will say, actually, no, we're going to challenge that because we want to make sure that we have scan slots for those women who need them most. But also engaging with families. Tommy's have done, as part of Tommy's, there's been a big research project looking at its implementation. But women, those conversations with the women explaining about Tommy's have to be really high quality, because they come and say, look, I had a pregnancy back in 2018 and this is what happened. I'm now 5 years older and I'm not having the scans I received 5 years ago. Why is that? So it's about being able to explain why we are using new specific tools to be able to provide that benefit. And that goes for both aspirin and scan pathways. But Tommy's is there to be able to support those high quality conversations, and we keep on going through it again and again with our staff. There are more challenges. It's thinking, just wait a minute. Yeah, so it doesn't integrate. When we started looking at implementing Tommy's, we were absolutely promised that within 18 months it was all going to be seamless within Badgernet. We should have thought at the time, given that you want a small addition to Badgernet, it takes you 6 to 9 months. That's not going to happen. So we're nearly 4 years down the line, and it's clear that that integration is not coming anywhere soon. And therefore, there's lots of additional workload for our staff on the shop floor, but they can now see the clinical benefit for that, and therefore are happy to continue with it. At the end of the pregnancy, we have to complete a pregnancy outcome form. outcome form. There's no clinical benefit for those staff on the shop floor, and therefore they feel like they're being asked to do a task which doesn't give them any benefit for that individual woman at the time. And that's where the integration would make a massive difference. The tool is developing over time, so the launch project compared to what we have now is very, very different. It is improving, but that's hard for midwives when they keep on going in, and every time they go in it looks slightly different. I've noted you, Sian. But also we've had lots of challenges with SBL and MNSI and that integration. Because it's a new tool, actually we've had to go to the ICB board to get it approved so that we were compliant with our SBL implementation, and we've had MNSI reports which have been shared with families in draft form talking about that we weren't providing guidance with care within national guidance, although Tommy's is absolutely mentioned within SBL. And so those conversations we have to keep on having again and again. So absolutely there have been challenges with mainly the integration of the platform and that educating the staff and our workforce, but there is absolutely clinical benefit. And then now it is business as usual, and hopefully as more sites come on board with the partner trial, it will become a little bit more sort of knowledgeable across the region and nationally. Thank you very much. A whistle-stop tour of Tommy's.
Thank you, Sian. Any questions? It's been a brilliant presentation, and it's great to see the progress that's being made on this as well. Charlotte.
Oh, thank you. Thank you, Sian. Brilliant presentation. Do you have any information if trusts do want to sign up to the project, how they go about that, please?
No, I'll put the partner trial email in the chat. Absolutely. So there's a few, I don't know quite where they are with their recruitment. They are definitely sort of a little bit down the line, but I'll absolutely point you in the right direction. As I say, it's not without its challenges, but if I had my time again, would I do it? I would.
Brilliant, thank you.
Great. Thank you to everybody. So moving on, if there's no more questions, this is my reflections and thanks. So thank you to all the speakers today. I think we can all agree we've seen absolutely amazing projects, progress, and what looks to be a very interesting future being presented to us in the area of digital. I'd like to say a big thank you to Jo for her bravery. I know she's had to leave, but I still think to say it's so brave in sharing your story like this, and it shows us then the need for things like the WEP programme, producing consistency, information, support for women, so perhaps they don't have to go through that pathway again. And great to see the impact it's making there in bare facts and figures that supports this going forward, and I'd like to see what comes out in the future. UHS, thank you so much about the work that's being done in equipment checks. Definitely saving time and being more effective, and a great leap forward in patient safety, which can be shared across the whole of the NHS in a way which really links into the 10-year-old plan. To the Raham project, I would really like to do more about this because I think it's so important for communities speak to their own communities, myth busting, and they're given that support, and that's a fantastic project for doing that, and it's been supported by the LMNS. And for Sian talking to me, which I'm going to call Tommy's tool now rather than app, which is really great to hear too about the implementation element from you, because as you say, it's not plain sailing, but this is a great way forward that will help reduce variation as we go forward. If anybody's got any questions that have occurred to them after we've gone through the session, please email us and we'll pass it on to the right people. Everything will be up online soon. And can I thank you all for your time at NG today? And we would love to hear and learn from what we've done today. If there's any comments you'd like, please feeding the feedback form, which is here, and it'll also be in the slides, and we'll send it out to you all when we send out the slides from the day. So again, we're 1 minute over. Thank you so much for your time and energy today, for listening, for being present, and I look forward to hearing from you all on our next day, which is the 16th of September. Look forward to you at the next webinar. Take care.